This week on the BackTable podcast.
There is something called as the reuse policy, wherein for unaffordable patients, if they cannot afford, catheters and wires are reused, obviously after sterilization procedure and everything. And so there is a reuse policy in India, and which was a shock to me when I came in over here, because I have never heard of this. And but there is no other choice. And if we have to do it for everybody, if everybody cannot cater to the, if we have to cater to the needs of each and every person, we have to do this, unfortunately. But yeah, equipment is an issue. Having said that, the basic equipment is always there, but yeah, not everything.
Hey guys, and welcome to the BackTable podcast, your source for all things IR and endovascular. I'm Chris Beck, and I'll be your host today. Per usual, we are always on the lookout for more feedback. So if you have some for us, please reach out to us. The address the website address you can get us at is www.backtable.com, or our Twitter handle is @_backtable. First off, I'd like to thank our sponsor, RadPad. Guys, we appreciate the support. RadPad was developed by physicians for physicians. It's clinically proven radiation protection during DSA and fluoride-guided procedures. Don't bet your career or your health on anything less. Trust RadPad radiation protection shields for all your interventions. See RadPad for more information, or reach out to them at info@radpad.com for a free radiation and no-brainer radiation protection cap. Out of the way, I'm happy to introduce our guest today, Deepa Shree. We'll be talking about the practice of IR in India. And Deepa, would you go ahead and introduce yourself and tell us a little bit about your practice?
Right. I'm Dr. Deepa Shree, and I'm a practicing interventional radiologist in India. And here, I've been in India for the last 6 or 7 years now. And I must say, in the last 7 years, I have seen a vast change in IR since I have, I've been over here. And prior to that, I was in UK, and I was a radiology resident, and later on I moved on to IR, and that's where I am today. And I'm a clinical lead at a hospital called as Dr. Rela Institute and Medical Center. It's a liver transplant center. So my IR work is predominantly HPB interventions. HPB actually stands for hepatopancreatobiliary interventions, predominantly liver interventions.
Would you back up a little bit? And first, I kind of want to dig into how you actually got into interventional radiology and what IR training looks like as far as med school and residency in India.
Right. I've completely got trained in UK. So the scenario is totally different in India. In India, we have 3 years of radiology program, which is called as MD in radiology. And there is something called as a DNB program, which is Diploma in National Board. So you get into those, the 3-year program. And for someone to get into IR, you need to search for an accredited fellowship in India. There are totally around 72 accredited fellowship programs in India. And usually it's a 1-year or a 2-year fellowship program. And that's what it is. And last year, they have introduced something called as DM in IR. So basically, you have 8 posts for the entire India to get into IR, or you have 1 or 2 year fellowship programs. And that's how it works. And unfortunately, I feel the 3-year program in radiology itself is too short to explore IR, because people who are radiology residents, they really do not get an exposure to IR until they finish off their radiology career. And that's when they get to know a little bit about interventional radiology. And that's how it works over here.
You did your training over in England, I believe?
Yeah, over in England. I was a radiology resident. I got into my radiology program there, and I'm from Yorkshire Deanery. So the way it works, I suppose you know about this. The way it works in UK, it's a 5-year program, and then with a fellowship program for 1 year or 2 year if you want to do IR. But the advantage at that point of time was there was something called as a focused individualized training scheme, which is called as a FIT scheme, wherein you get to choose your IR career right from day one of your radiology program if you want to. And I was lucky because I actually did, an observership in interventional radiology much before I got into this IR. So I did general medicine, I did MRCP before getting into radiology program, because in UK it's mandatory you do either general medicine or general surgery before you get into radiology program. So I did 5 years of general medical training, and during that time I had an exposure to IR. I had an observership for about 4 weeks, and that's where I built a flavor for IR. And I got trained in HPB interventions. I asked them if I could get trained exclusively in HPB interventions because I knew that I was going to get into a HPB center over here. So I wanted to be more focused in HPB because I knew there isn't a scope for other aspects of IR in India.
So whenever you were in the UK, it was 1 year of internship and then 5 years of radiology with different amounts of interventional radiology, with kind of like a dedicated focus on interventional radiology throughout those 5 years?
Absolutely, yeah. We have placements in IR right from our first year. If you want to, you can choose your IR from day one of your radiology training program.
So then you finish your training in the UK, and did you immediately go back to India to start your practice, or did you practice a little bit in the UK or somewhere else abroad?
I practiced a little bit in UK for 6 months after I finished my radiology program, and because I wanted to appear for the EBIR as well, which is European Board in Interventional Radiology, and it's an exam that we had to give, and so I had to finish that exam, and then after 6 months after practicing in UK, I moved back to India.
Okay. And that was always the plan to you to study abroad in the UK and then come back and take that skill set back to India?
Absolutely. Yeah.
Once you came back to India, what did it look like as far as like applying for jobs, looking for jobs? Like what did the job market look like in India when you were getting back to India to search out for an interventional position?
I would say I was probably lucky because the job market in India is not great as far as IR is concerned, because there aren't many interventional radiologists in the first place. People actually do not get into IR because there aren't many jobs, and most people, including the doctor fraternity, is not familiar with IR. So we don't get referred cases from a general surgeon or from a general medicine person. It's not very popular that way. People are actually not aware of IR. But I was lucky because of the center that I had chosen when I was in my third year of radiology training. That's when I had applied for jobs in India, and I have been offered a job saying that, if you come back to India, please get trained in HPB intervention, which is hepatopancreatibiliary interventions, and come out to India and then we'll give you a job. And that was a promise given to me. And because of that, I got trained, and then it was, getting a job was not difficult for me. I very easily slipped into the system over here because the job was ready, and I exclusively got trained in liver interventions. And it's a liver transplant center. So, the workload was just apt for me. But however, the scenario is quite different. If you generally apply to everybody else, I don't think it's the same. I was just lucky, I would say.
Wow. Then that is fortunate. So if we could take a step back, though, and I know we could do an entire podcast probably on the healthcare system in India, but can you give our audience a basic understanding of how the structure of Indian healthcare is set up?
The way the Indian healthcare is set up is obviously you have a government healthcare and it's a private healthcare, and we call them the corporate hospitals. All come under the private sector, but unfortunately, it's the private people prefer to go to a private healthcare because of the facilities and the infrastructure is probably good in a private healthcare as opposed to a government setup. Unlike UK, where I have seen, NHS is really great, and anybody can just walk into the NHS and you can get the treatment done. For example, if somebody needs an intervention, I don't think everything is available in a government setup. Even the interventional radiologists are very few in a government setup. So people preferentially, they choose a private sector, and it's quite an expensive job to get it done. There are a lot of insurance. It's not necessary or it's not mandatory to have an insurance, but yeah, it's quite an expensive job if you want to get it done in a private healthcare sector.
I see. So there's a public arm and then there's a private sector. and the
Yeah.
hospital that you're based out of is a private corporate hospital?
It is. Yeah, it is. Yeah.
Okay. So tell us a little bit about your practice in that whenever you took your job on for HPV interventions, like what does your day-to-day look like in terms of your, do you work 8 to 5? Do you take call? Do you do diagnostics? Is it exclusively interventional radiology? Just a little bit about what your day-to-day looks like.
Yeah. When I started 7 years ago, I took in both diagnostic and interventional radiology because I feel both are interconnected. And doing a little bit of diagnostic and also the interventional radiology department was not set up very well when I walked into this hospital. So I had to actually, start the IR practice over here. For that, I had to get into the diagnostic radiology as well. And the typical day when I started was more of, diagnostic radiology and very, few interventions at that point of time. Later on, we had to do a lot of marketing inside the hospital and then, just explain to people a lot of conferences, a lot of CMEs and, in-house meetings wherein people got exposed to different, interventional radiology procedures that we can offer. And slowly the practice actually, we could build up the practice over here. And later on, I decided to move on from diagnostic to exclusive IR. And that really helped me to focus on IR because I felt that there needs to be a fellowship program. And so I brought in the fellowship program in India so that I can train people. And so we got in the IR fellowship program as well. So like in any other setup, the IR over here, because of, I suppose the training in UK, it really helped me to set up with an MDTs, tumor board meetings and, the fellowship program, having an academic program, and at the same time, doing the procedures. In terms of the volume, it wasn't huge. And even now, I wouldn't say it's a huge volume, but I'm fortunate to be working in a transplant center because we get to do a lot of tumor embolizations, a lot of tumor ablations, because most of the patients have got HCC and, they come into the transplant center for the liver transplantation. So we do it as a bridge to transplant.
Sure.
And that's what keeps me busy over here.
After you explained all the things that, from the beginning of your practice to where you've gotten to now, it sounds like you covered a lot of ground. How long have you been in practice?
You mean the IR practice?
Yeah, the IR practice in India.
IR practice in India for I think it's about 8 years now.
Okay, so you started your job 8 years ago, and if I can summarize, so when you first started out, you were doing a lot of diagnostic radiology, and it seems like you were doing a lot to build up the practice yourself. And then at some point, you created enough work through physician education to where now you're fully interventional radiology? Yeah,
that's right. That's right.
Do you have any partners in your group or in the practice?
Partners, no, we don't have any partners in the group. But when I actually came in, there was one person who used to visit from another city to Chennai, where I live. And he used to come in every Thursday to do the cases here. I mean, there used to be 1 day per week wherein they used to schedule all the cases. So he was actually covering at that particular point of time. But as such, we don't have any partners. So I'm just on my own. And but we do have. I did take in a lot of juniors. We call them associate consultants and the fellows, and that's about it.
Okay, so after hours coverage for interventional radiology, how does that work? Are you on call all the time?
Yeah, we are. But as such, I don't know. It's a blessing in disguise, I would say, that we don't get disturbed often in the night. I mean, other than the trauma cases, which are very few, especially in the center where I work, or some bleeding cases. Other than that, we don't get disturbed. But otherwise, I'm on call 24/7. And we have fellows to cover some of the cases, but for certain crucial cases, I get to go in. But I wouldn't say it's that busy to disturb me every day.
Are there times whenever you go on vacation and then you have someone else cover you while you're gone?
I do have something called as a MOU, the Memorandum of Understanding with another consultant in a different hospital. So before I decide to, recently I've been on a vacation for 4 days, and because of the MOU, I just asked him to cover up for any of the emergency cases. And it so happens that when you're out on a vacation, you do get some emergencies only during that time, and we ended up having a couple of emergencies, and it was well covered. So that way, I think we are, we do have an MOU with other people, other guys in other hospitals. Yeah.
So you touched on something about the fellows. So you have fellows, and you have I think you call them junior associates. As far as as far as that goes, if you have a case that's of low complexity, it's a situation where you can entrust that to the fellow, and you may not have to come in to supervise them. Is that right?
That's right. I mean, we do have something called as assessment for I mean, it's a 2-year fellowship program that we run. A second-year fellow is allowed to do certain cases independently, based on the assessment, based on the level that they achieve, from level 1 to level 4, depending on the complexity of the case. I mean, we have the credential and privileging system over here, so wherein I give them the privileges to do certain cases when I'm confident that this person can handle this case very well. So yeah, fellows usually they're quite competent to handle most of the cases other than complex ones.
Okay. So a senior level fellow, so someone who's maybe at a level 4, I assume that's the highest level, they're towards the end of their fellowship and they're soon to graduate. What are some of the cases that they may come in and be comfortable handling on their own without you actually in the control room supervising?
Well, I mean, as I said, the last this week when I actually was out on the vacation, we had 2 cases wherein there was a bleeder, who was actually it's a post procedural bleed. Patient ended up having bleeding in the it was an intrahepatic arterial bleed, and they could just go in and embolize it, and the patient was absolutely fine with no problems. And in fact, it was a post-transplant case, so getting into the liver post-transplant because of the anastomosis can be difficult, but I don't think they had any difficulty in getting inside and then doing the embolization. So I would say probably embolization in trauma cases or any of the bleeders, I'm happy for them to do. And any of the emergency PTBDs, biliary drainages, if somebody is in sepsis, I'm quite happy for them to do as long as the system is dilated. And I think one of the things that we need to, incorporate as part of the fellowship is, if they're actually not comfortable with any of the cases, I would tell them not to touch and just to call for help, because we do have another person who's covering us. And so generally, it's if they're confident about a particular case, they usually go in. Having said that, it's just a phone call away to call another person to come for help.
Sure, of course. So I guess even when they are taking on cases, if they get into something that they don't feel particularly comfortable with, they have a backup which they have a backup.
Absolutely.
Yeah, that's great.
Yeah.
I think that also builds a certain level of autonomy with the fellows and helps them build confidence and troubleshoot on their own rather than just always looking to someone to tell them the answer. So I think that's a good setup.
Absolutely. I've been a fellow myself, and it feels great when you do a case independently and when the consultant, trusts you so much that, he just lets you crack on with the case. I think it just boosts our confidence. And I think it's a very fine line. But I think this is important at times, I feel, to just give them the opportunity to crack on with the cases.
Yeah, absolutely. So getting in a little bit to the system in which you operate, if you're at a private corporate hospital and you have patients that come in, how is the fee schedule based? Is it somewhere where, like, if someone's having, like, if you just take me through what it looks like to get a consult with you and then go through like an outpatient procedure, like an embolization of HCC, how does that, are those patients aware of the cost ahead of time? Do they have to pay ahead of time? What does that look like for the patient end?
Yeah. They are, usually what happens is they usually go and see, the clinician first and, or the surgeon. And, we made it mandatory. I mean, when I first started here, you won't believe me. I would just get a call in the middle of the night saying that tomorrow a patient is posted for TACE. And I would have no idea about, that particular patient, who actually spoke to patient, has he been counseled, what exactly is happening. So that was the scenario at that point of time. But later on, we brought in this culture of seeing the patients and then counseling them, getting the consent and talking to them about the billing and, the cost, about the procedure. Everything has to be explained to the patient, prior to, me getting in and, doing something on the patient. So nowadays, the way it works is usually they see the clinician, then they come over to me directly. They don't actually pay me for my consultation because they would have already paid the surgeon or the clinician, because that's when they would send patients to me. If they had to pay for my consultation, usually they would say, why do they have to pay separately, for you and for us? So usually what happens is they pay them and then they would just come and see me. I would talk to them, explain to them about the cost of the procedure, the pros and cons and everything, and then send them over to the billing department. usually they get counseled about the cost of the procedure, and they need to pay about, we have a basic tariff wherein they need to pay for the, just for the, the basic procedural cost, and whatever consumables we use, about the microcatheters or whatever we use, that's an extra. So we just give an estimate, about the procedure, and, they just go on with that. So they need to pay at least 50% of the procedural cost before the procedure, and the remaining they pay after the procedure.
Okay. So that's pretty neat in that they see you in consultation. It's a free consult for the patient. And then after that, you kind of forward them on to your, the hospital has a billing department that they go in. And I guess the billing department has a basic understanding of what procedure they'll have done. They have a list of things that they can kind of reference, and the patient gets billed for 50% of the procedure. And then once that payment's been made, the patient, the procedure actually happens, and then the balance is paid after the procedure, I guess.
Yes, at the time of discharge, they pay the remaining amount. Yeah.
And then patients who are in the hospital for one reason or another, say, they're having a liver transplant and they have some complication related to the transplant, like, it's a long, extended, protracted hospital stay with a couple of things that haven't gone perfectly right. And you have to do something like either a biliary drainage or an abscess drainage. Is there a fee schedule for all that when patients are just having these long hospital stays? How does that part of it work?
I mean, to be very honest, everything can be customized. I mean, they would have, shelled in so much of money for liver transplantation and for a prolonged stay. So what we do is, although the biliary drainage procedure or TACE or any procedure for that matter, although it's an expensive task, we do consider in certain cases wherein, we feel that, the billing has exceeded so much that they cannot afford it. So we do consider certain cases, and but otherwise, if they can afford, usually they charge the full amount. Having said that, even if it's a complication, it's sometimes it's we have to specially consider for certain cases. But yeah.
So sometimes special consideration is given for the fact that, you were supposed to have a liver transplant and it was supposed to go XYZ, and you had some deviation from the plan, which required some additional medical care, that potentially that medical care is kind of say, oh, well, we didn't intend on that happening, so we'll write that off.
Exactly. Yeah, exactly. And that happened in many cases, actually, quite a few cases where we had to do that. Yeah.
Sure. That makes sense. So digging in a little bit to the equipment and the resources that you have available, can you compare your current practice in terms of what resources, equipment that you have available to you is compared to your training in the UK?
I mean, the only thing I learned is, I suppose when I was in UK, the equipment, we had like a storehouse of equipment. If you need to do an EVAR in the middle of the night, everything is available. All the graph sizes are available. Everything is there. But unfortunately, it doesn't work like that over here. I mean, we don't have any equipment. I mean, other than the basic equipment, like, whatever you need for embolization and for biliary drainages and stuff like that. In terms of, for example, if somebody has a ruptured aneurysm, if you want to do something in the middle of the night, I don't think we can do that over here because, the equipment is not available. And so unfortunately, that's the scenario. I mean, we do, I mean, it's just that I suppose that's a compromise that we have to take in India, because most of the hospitals, no matter what, we cannot afford so much to keep each and every equipment handy, and most of the companies, vendors, they themselves are not happy to leave it on stock over here. So yeah, that's a drawback. And there's one more thing that we often do in India is sometimes there is something called as the reuse policy, wherein for unaffordable patients, if they cannot afford, catheters and wires are reused, obviously after sterilization procedure and everything. And so there is a reuse policy in India, and which was a shock to me when I came in over here, because I have never heard of this. And but there is no other choice. And if we have to do it for everybody, if everybody cannot cater to the, if we have to cater to the needs of each and every person, we have to do this, unfortunately. But yeah, equipment is an issue. Having said that, the basic equipment is always there, but yeah, not everything.
So tell me a little bit about the reuse policy, and that, I mean, I can imagine a scenario in which a lot of things can be reused, but then I can also imagine a lot of scenarios in which things can't be reused. What are some of the things that can get reused after the sterilization process that maybe you were surprised by?
In the basic catheters, the reuse policy is only for patients who are serology negative. They should not have hepatitis B or hepatitis C. So only those patients who are serology negative, we tend to reuse the catheters and the wires as well. The shock to me was a Terumo. The hydrophilic coating of the Terumo, it's gone by the time you reuse it once. You send it to the, it's called as the ETO solution that they put in, and then they sterilize, and then even the wires are sterilized, and then they gave Terumo wire to me first time I had to get inside the hepatic artery, which lost the hydrophilic coating on it. And negotiating across, the hepatic artery with something which has lost the hydrophilic coating was so difficult. We can end up dissecting the artery by doing that. So that was a definite shock to me, because I was not at all happy doing that. And having said that, even today, I don't reuse the wires, especially the ones with the hydrophilic coating. And some of the catheters with beacon tip, if you reuse it for 3 or 4 times, nowadays I think we've just got one with straight catheter with no, the tip attached. But prior to that, even some of the companies had this kind of tip which is attached, the hydrophilic tip attached to the rest of the catheter, and they tend to break. And it was one of the patients I was doing it, and then it broke, and I had to snare that thing out. So there are a lot of So these are all the complex things that we have to handle by using, because of this reuse policy. But it's something that I cannot avoid, unfortunately, in certain patients.
Sure. What are some of the things that get reused and sterilized and work fantastic? Like you can't tell the difference the second go around. Like I can see a lot of scenarios like with a Benson wire and Amplatz wire where I can't imagine it makes a whole lot of difference.
Yeah, absolutely. Yeah. Any of the stiff wires, Benson or Amplatz wire, or even the sheath for that matter, needles, sheets, the puncture needles, the sheets, they all can be reused. But not the catheters, even the microcatheter for that matter. That I don't think we can reuse a microcatheter, especially the one with the inbuilt wire in it, like for example Prograde or any of these microcatheters. I don't think we can reuse that because it so happens that we don't even know when they are going to give us the the reused microcatheter, because if something is not available, they just give in the reuse. And in that when you're actually dealing with a trauma case, if you have to get into some kind of an artery with a complex anatomy, we really struggle getting inside the artery. So that kind of scenario. But definitely the sheets, the puncture needles, some of the stiff wires, we can reuse them.
And can you talk a little bit about the equipment that you have in terms of your C-arm, your ultrasound equipment, your CT table? Are a lot of these comparable to what you had in the UK in terms of the quality and some of the bells and whistles that are equipped with them?
Yeah, equipment is great. I don't think we compromise on the equipment in terms of the quality. We have a 128 CT scanner. We have a Siemens CT scanner over here, and then we have a 3 Tesla MRI, and we have a Philips cath lab unit. It's it's a hybrid unit. Both the cardiologists and interventional radiologists can use. It's a 20 system, so we can. That's the only downside to the cath lab equipment, I would say, is we don't have a biplane and we don't have a DynaCT incorporated in it. Unfortunately, in this particular hospital where I'm working, it was already bought much before we came into this hospital. So they couldn't revamp the equipment at this point of time, but definitely it's in the agenda, planning to get a DynaCT and a biplane as well in future. So those things are readily available. I don't think they compromise on that, because any of the corporate hospitals, they're happy to buy the equipment, the top class equipment. Even the ultrasound machine that we have, I use the RS80 Samsung ultrasound machine, which has got the fibro, the shear wave elastography in it. It has got the contrast ultrasound option in it. So that way, it's pretty good.
Did you say it's got the contrast ultrasound component to it?
Yeah, it's got a contrast ultrasound component to it. Yeah.
Do you guys do a lot of contrasted ultrasounds?
We did few. I did it only for academic purpose. For example, like a pre-TASE and a post-TASE contrast ultrasound, something like that, for lesions which are not only for academic purpose, but generally we sway more towards CT at our institute. It's simply because, surgeons are very comfortable with CT and, they really prefer to see what's happening with the CT. But in certain patients, they're in renal failure and we can't do CT for whatever reason. In those patients, we tend to do contrast ultrasound, but not as a routine.
Oh, I see. I don't know if this comes as a surprise for you, but and maybe I'm not exactly representative of what everyone in the U.S. is doing, but I virtually know zero about contrasted ultrasound except on experimental studies. One of the places I trained at, we did some some contrast enhanced ultrasound, but otherwise I just know very little about it. And I don't think I've seen more than two. And so I would feel extremely uncomfortable trying to like diagnose an HCC or characterize any liver lesion based on it. Exactly. So that's fantastic that you know how.
Yeah, I mean it's actually good when in some of the lesions which are so obscure that you really can't for example, if you want to do let's say do a biopsy. And CT angulation is quite difficult, but on ultrasound, it's kind of poorly visible. I think contrast does help in certain scenarios. I mean, there are only 1 or 2 cases wherein I used contrast ultrasound for biopsy to see the lesion. But other than that, we don't often use much. But just for academic purposes, I just tend to use it so that I just get to know what's happening, because it's even the contrast that we get is quite cheap. The bubble contrast that we use for contrast ultrasound is quite cheap compared to the routine contrast. So and the module is readily available, so we tend to use that.
Sure. So for things that are, I think I would qualify these procedures as low-level interventional, basically maybe not even much interventional radiology is required for training to accomplish these procedures. Like I'm thinking along the lines of like abscess drainages, lumbar punctures, things like this. Are you responsible for all of these procedures? Basically anything that may require like any kind of needle in your practice, or do some of the diagnostic radiologists in your practice participate in some minimally invasive procedures?
At our institute, it's an exclusive IR thing, including the ascitic, drainages or pigtails or tappings. The pleural drainages, everything is done by an interventional radiologist. Lumbar punctures, we don't often do them. It's usually done by anesthetists over here, and including the port insertions and the lines are done by the anesthetist over here. But yeah, the rest of the things when it comes to pleural and ascitic drainages and other minimally invasive interventions, we do it. Fellows end up doing it, but I feel it's important that we have this component to us, because in terms of basic needle skills, I think fellows get trained in that, and we tend to do at least 10 to 15 cases of ultrasound guided interventions every day, and that really helps in enhancing their the needle skills or the handling skills. So yeah. Sure.
Did you say that the anesthesiologists do basically all the line work, like a anesthesiologist do a port?
Absolutely, yeah, they do that. It's kind of fragmented over here, especially in India. I think we are probably losing IR to various other specialties, which is a sad part. Anesthesiologists, they tend to do lines and ports, and nephrologists tend to do Hickman lines and perm cats. Vascular surgeon tends to do, laser ablation of the varicose veins or the microwave ablation of the varicose veins, and EVAR. Everything is done by the vascular surgeons. Even the iliac angioplasties or the peripheral work, below-knee work, most of the work is done by them. So all that we are left with is just the liver interventions for now, and the neuro interventions, I would say. And even the neuro interventions, it's kind of going away from us. There are neurosurgeons who have started doing a lot of neuro interventions, who get trained abroad, and then they come in and they start doing it. Unfortunately, patients don't come to us directly. For example, if somebody has got uterine fibroid, sure. When I was in UK, we used to have fibroid clinics wherein they just come in to see an interventional radiologist with fibroid problem. But over here, that's not the scenario. They go to a gynecologist, and gynecologist never sends the patients to us. Sure. Usually, they're offered hysterectomy or something like that. So yeah. So it's definitely getting fragmented, and it's going away from us, and something needs to be done for this right now. Yeah.
Sure. Well, so kind of talking about that in terms of competition versus collaboration with other specialties, the situation which you just described seemed like it was more competitive market, where people were kind of getting into each other's wheelhouses, and there was a little bit of competition for cases. Are there any instances where you collaborate with other physicians, like making inroads with OBGYNs to start like a fibroid referral, or working with cardiology or vascular surgery on complex below the knee interventions, like things like this to maybe increase the caseload and bring in some of these things into the scope of your practice?
I mean, we have tried, but the problem over here is, when it comes to, because it's a private practice, everybody is worried about, the revenue for their own department.
Sure.
And, we all are supposed to show the revenue for the department that you run. And when it comes to that, and also there's a cost element as well. For example, if somebody needs, somebody has an AV fistula, and, instead of, rescuing the fistula, if the fistula is failing, I spoke to a lot of, my colleagues, and, I said, if fistula needs to be restored, it needs to be rescued. But unfortunately, what happens is, a fistuloplasty or, thrombolysis of the fistula is a lot more expensive to the patient than creating another fistula. So they end up getting, one fistula after the other, because it's just because, the procedure is so expensive and they cannot afford the procedure. And that's partly one reason as to why we probably, even despite the collaboration, it doesn't work, because of the cost factor over here.
I see.
And and there are other scenarios wherein somebody has got let's say an RCC, a renal cell cancer, and
Sure.
although ablation is the preferred choice, and nephron sparing should be done, but they prefer partial nephrectomy for the patient, because again they compare the cost and they say, okay, if ablation is going to cost you 1 lakh in Indian amount, or 1.5 lakhs in Indian amount, this it can be done cheaper than that. A partial nephrectomy is probably cheaper than that. So patients actually even they prefer that. And and that's how they are counseled as well, saying that it's a cost is probably the same, and why not go for this rather than this. So sometimes I feel we are just moving away from evidence-based practice to the cost-based practice over here.
How much did you say that a renal an RCC ablation would cost?
I mean, it
Roughly,
costs
and I
about,
won't hold you to it. I know it's a ballpark.
it's about 1.5 lakhs in Indian money, 1.5 lakh rupees in Indian money, $2,000 US dollars. So that's the cost of RF ablation over here.
Okay, I was just curious to get a rough ballpark of what things cost.
Yeah. And
So-
that's how the TACE also costs. TACE is probably around 2,500 or 3,000 US dollars.
Okay.
The transarterial chemoembolization that we do. Yeah.
Right, very interesting. I'm always interested in terms of collaboration versus competition on one topic in particular. Who does IVC filters in your hospital?
It's a mix. I mean, at our hospital, usually I do it. But if a cardiologist sees somebody with an IVC thrombus, or if he gets a patient from somewhere, usually he ends up doing and sticking in an IVC filter. But yeah, it's done by a combination of cardiologists, interventional radiologists, and vascular surgeons. But at our hospital, I've seen cardiologists doing it, and I do it, and I've seen a vascular surgeon doing it as well. Yeah.
I see. Is there still a big push to put in retrievable filters, and then on the back end try and get those filters out?
I mean, what I've noticed is usually they put in, but when it comes to taking out the filters, it's usually an IR guy who ends up taking the filters out. Sometimes I feel, retrieval is probably, you probably need a little bit of more training in retrieving the filter. But deploying, I probably, they probably feel it's easier to deploy a filter, but I haven't seen anybody retrieving a filter. But there was one occasion wherein one of the cardiologists tried to retrieve a filter, and the filter leg got stuck in the renal vein. And that was the point wherein an IR was called for help, because it was so difficult. The filter was completely tilted, and two legs were in the left renal vein, and it was so difficult to take it out. And that's when we were called, and we had to go in and take the filter out. But yeah, that was the only occasion wherein I have seen somebody attempting to take the filter out.
Okay. Well, seems like maybe more appropriate for you to be taking on those cases anyway.
Yes, yeah.
As far as liver-directed therapies, is there room for yttrium or Y90 radioembolization?
Yes, yeah, we do a lot of Y90 cases over here, and it's very, very expensive compared to chemoembolizations. But yeah, for the affordable sector, we do transarterial radioembolizations. Yeah, that is available over here.
Is it just for HCC, or do you also see a room for it in your practice with regards to metastatic disease like metastatic neuroendocrine or colorectal?
Yeah, not for colorectal, but I have done it for metastatic neuroendocrine tumors. For colorectal, for some reason, it has to come from an oncologist or an oncosurgeon. And I mean, at our setup, I haven't seen a lot of metastatic colorectal mets being treated with TARE, but definitely for neuroendocrine and HCCs. A lot for HCCs. Yeah.
Okay. And when you do, and we don't have to get too far into it, and when you do for HCC treatment, are you guys using glass or resin?
We use the resin microspheres.
Are there any challenges that whenever you started your practice or even the practice now as being a female interventional radiologist in India?
Yeah, in terms of being a female interventional radiologist, I don't know. I mean, I don't think I had a tough challenge, I would say, in terms of being a female IR. But having said that, there are only 6 or 7 practicing, women interventional radiologists in India. It's kind of, you go to a conference and I don't have a company. That's all I feel is a challenge for me because, it's studded with men and there are about 300 people sitting there and I'm the only person, me, or, there are just 2 or 3 people sitting there. But other than that, I don't think it was that difficult. But a lot of people are not coming forward to take up interventional radiology. It's only because they have this, because of the lack of the training programs, I would say. Not every city has got an accredited training program. So most of the women, they don't move from one city to the other city to get trained in IR. I just wish there was a training program in every city and wherein they can just choose an IR and then they can just get into it easily. And there is also this, this misconception about the fact that, about the fertility and other things in India, wherein, people feel that, getting into IR, it's probably is not the thing for women. And so that kind of a thing. But other than that, I don't think there are a lot of challenges. Even the emergencies, we just get to go. And nowadays, the infrastructure in India is definitely a lot better than what it was even when I came to India some 7 or 8 years ago. I think we can just go in the middle of the night now, which was not the scenario before. And but it is definitely improving. But I think it's a lack of training programs, which is probably responsible for women not opting for IR, I feel.
That's interesting. So I'd heard a portion of your talk in 2015 about the infrastructure being a struggle in terms of transportation, especially for emergency cases. But that's been on the up and that's been improving, which has made it easier to facilitate, travel to and from the hospital during, after hours.
Definitely. Yeah. Definitely. There are a lot of these, the services, even the Ola and Uber and all these services, which never existed in India before. And all these things, they're quite secure that way. And, we don't have to really struggle about the transport or the commute anymore. And so that way, I think it's definitely shown a lot of improvement. And every hospital is arranging a commute for, women radiologists. If we have to travel in the middle of the night, hospital sends us a cab and, we can travel in the hospital cab. We can just finish it off and come back. So that aspect has been taken care of. And I don't think it's no longer an issue, but it's just the training that we need to focus on and we need to, encourage women to take up. So that's what needs to be improved upon.
I also found it fascinating, Deepa, your experience with interventional radiology in terms of like you basically came into a private practice group. Or from the description, it sounded very similar to going into a US-based private practice group. You didn't have a lot of IR. You did physician outreach and physician education, and then now you have a lot of IR, and now you've transitioned from mixed IR DR to full-time IR. That's like a mirror image of what a lot of people are doing here. So I think that's fantastic.
That's great. Thank you. In fact, over here, I just try to get into a lot of digital media and try to expose, IR on a digital media as well. Because of that, I think it's reaching out to people. But you won't believe what I had to do to reach out to people. Because if I just post a video about a uterine fibroid on a digital media, nobody's going to look at that. Right. So I had to literally put in a lot of entertaining stuff before I actually, exposed myself as an interventional radiologist. I'm a Zumba trainer and a Zumba instructor. So I had to put in a lot of my Zumba fitness videos and everything so that people know who Dr. Deepa Shree is. And so they kind of look at me as, okay, fine, she is somebody who's doing other things. And then later on, I put a video about a uterine fibroid embolization, then people go in and watch. So it's that kind of mentality and scenario. And it's a very tough market to crack on. So
So it sounds like social media is a part of the marketing or the practice building strategy then.
Oh yeah, a lot, definitely. I mean, for me, I think most of my patients, it's through social media, and then we also have got digital media marketing experts, wherein they do something called as the search engine optimization. So
Right.
we do have certain guys. There are a group of companies, and wherein they send us patients. For example, all the varicose veins patients. They come to us through search engine optimization. If somebody is looking for varicose veins on the net, I think this thing pops up, this company pops up during the search, and they try to contact that company, and then they direct them to us.
Well, that's fantastic. And so you linked up with these guys, and what they do is they basically connect people who are possibly in your area and looking for varicose vein ablations directly to you.
Exactly. Yeah, exactly. And it's amazing to see the number of, I've never seen, before the tie-up, I hardly used to see 1 or 2 cases per month, but every day you get to see 6 or 7 patients. And sometimes I wonder, where did you all go all these years? And it's just that these guys, they do this amazing job, and they just filter these patients, and then they just bring these patients to us. Apparently, even the video engine optimization also works very well, is what they say. Somebody tries to go in, nowadays it's an era of videos wherein they try to go to YouTube and then try to look for varicose veins treatment. And at that time, this window pops up saying that, if you're looking for this, try to contact us, and then they put them through to us. Yeah.
Wow, that's a great service. And that's great that you got connected with that. How long have you been using that?
This I've been using for nearly 10 months, I think.
Okay, so relatively new, and it seems like you're having a good experience with it.
Yeah, definitely. Yeah.
That's awesome. Sure. All right, Deepa, I think we covered a lot of material here. Is there any stone we left unturned, or is there anything else that you wanted to tell us?
No, I think you pretty much covered everything. So, yeah.
Right.
So, yeah, I think
well, that's fair. Well, we really appreciate you coming on and kind of giving us some insight into your practice and into the interventional radiology situation in India. I found it very interesting. Guys, I think that's going to cover today's topic. We covered a lot of ground today. Really good discussion. To our audience, if you guys enjoyed this podcast but would like more, go ahead and check out our show notes to this episode. I'm going to be posting them on the website, and there will probably be a link to it whenever we post the episode on Twitter. We'll have a brief summary of the talking points, and although we didn't reference any articles, we'll always post those in the show notes. If you enjoyed this podcast and want to support the show in any way, here are 2 easy ways. Number one, take 1 second and press the subscribe button on whatever platform you're listening to. It just helps these platforms like iTunes or Spotify know that you guys value what we're doing and you're interested in getting our latest content as it's coming out. Secondly, if you're really getting a lot of value from these podcasts, please go to iTunes and leave us a short written review. It helps us in a lot of different ways. We appreciate the feedback. So that wraps it up. We'll see you guys next time. Thanks.
Thank you, Chris. Thank you.